Good evening, everyone. Thank you, South Asia, for this opportunity. I'm Lara, Ghaddar, a second-year fellow at the American University of Beirut, and I will be presenting today a successful implementation of a modified St. Jude Total 15 protocol for treating children with acute lymphoblastic leukemia in Lebanon. Lessons for low and middle-income countries. To start with, this is our center. It was established in 2002. It provides free treatment to all children with cancer on a first-come, first-served basis, and it serves as a major referral facility. Before our center's establishment, the cure rate of pediatric ALL in Lebanon was 54%, and death rate was 32%. After the center's establishment in 2002, we began treating children with ALL using the St. Jude Total 15 protocol without any modification. Survival rates improved significantly to 88%. However, some patients died during induction and early maintenance. 8 patients died, 4 of whom were in remission. We also had an unexpected complication of CMV retinitis. 4 cases of cytomegalovirus retinitis occurred unexpectedly during the maintenance treatment phase, accounting for 8.6% of the patients treated on the intermediate high-risk arm. 2 out of 4 have ongoing partial blindness. In 2016, we committed to making several modifications with the goals of reducing mortality rates during remission, eliminating CMV retinitis, minimizing neurotoxicity, and preserving the good outcomes. To address these issues, starting January 2016, we amended the St. Jude Total 15 protocol by stopping vincristine and dexamethasone pulses at week 69 of maintenance for all patients, decreasing vincristine to 1.5 milligrams per meter squared with a maximum of 2 milligrams, and omitting daunorubicin from reinduction 2 of maintenance for low-risk patients. Between January 2016 and January 2022, 127 consecutive newly diagnosed ALL patients aged 1 to 18 years were enrolled in a modified CCCL protocol, which was based on a modified St. Jude Total 15 protocol. The AUB/MC's IRB gave its approval to the treatment plan, and parents signed an informed consent. To treat patients, we classified them according to the St. Jude risk stratification into low risk, intermediate risk, and high risk. This is a picture of the protocol we used, and in blue are the amendments we made. So to start with patient characteristics, 55% of our patients were males and 32% were 10 years of age and above. 74% had initial white count below 50,000 and 26% had 50,000 and above, of whom 16% had 100,000 and above. 82% of our patients were of B lineage ALL, 16% had T lineage ALL, and 2% had mixed biphenotypic leukemia. 22% had favorable DNA index of 1.16 and above, and 2% had hypodiploidy. According to molecular studies, 11% had translocation 1221, 5% had translocation 922, and 4% had translocation 119. We did not have any case of translocation 411. 10% had initial CNS leukemia, 5% had initial traumatic LP. We intensified intrathecal treatment for any patient with traumatic LP because we anticipate that the peripheral blood is infiltrated with the blasts. This is despite all efforts to reduce the incidence. We transfused platelets before, had it done under general anesthesia, and by the most skilled physician available. Day 15 MRD was positive in 26% of the patients. We started with 68 patients on the provisional low-risk arm. 10 patients had MRD day 15 above 1, so 15% were upgraded to the intermediate high-risk arm. End of induction day 46 MRD was negative in 94.4% of the patients and positive in the rest. So with the 58 patients with provisional day 15 low risk, 2 of them had positive MRD at end of induction and were upgraded into the intermediate high-risk arm. So we ended up having 56% of our patients treated on the intermediate high-risk arm and 44% on the low-risk arm. We did not have any case of death in remission. No CMV retinitis, patient required PICU admission for pneumonia. We had 2 cases of meningitis, 7 cases of pancreatitis, 17 nephritis, 1 mucormycosis, 1 aspergillosis. We had 37 cases of pneumonia, 27 cases of diarrhea and epilepsy. We had 13 cases of thrombosis and vincristine toxicity. However, we also had another unexpected complication. After week 120 of maintenance, 10 males had late reactivation of EBV and CMV. None passed away and all recovered eventually. Discontinuing chemotherapy completely reversed this activation in all but 2 patients who developed EBV lymphoproliferative disease and 1 secondary HLH. All recovered eventually. Patients with EBV lymphoproliferative disease were treated by discontinuing maintenance chemotherapy, rituximab, antiviral, and a low dose of cyclophosphamide. Both are in clinical remission. Response to treatment. 94.4% of our patients are alive and in clinical remission. We did not have any death in remission. 1 patient had refractory ALL, 14 cases of relapse, which is 11%. We had 2 cases of secondary AML, 1.5%. We did not have any abandonment of treatment or loss to follow-up after end of treatment. That overall was 7 patients, accounting for 5.5% of the total. This is the site of relapse per risk group. For the sake of time, I will not go into details of the relapsed patient. The overall survival and event-free survival, the median follow-up period was 51 months, with a range between 15 and 85. The overall survival for all studied patients, the 5-year overall survival estimate was 92%. And the 5-year event-free survival for all studied patients was 86%. For patients treated on the low-risk arm, the overall survival was 95%, and the event-free survival was 91%. The overall survival of patients treated on the intermediate high-risk arm, the 5-year overall survival was 90%, and the event-free survival was 83%. This table shows the Kaplan-Meier estimate of the 5-year overall survival and event-free survival of all studied patients, of patients treated on the low-risk arm and patients treated on the intermediate high-risk arm in the period before Total 15 amendment and the one after it, with a 95% confidence interval. Results showed improvement compared to the prior period. So as a conclusion, despite reducing and eliminating doses of chemotherapy, this protocol achieved excellent outcomes, and it did not adversely affect survival rates. It was associated with elimination of CMV retinitis and death during remission, as well as less severity of viral illness. The benefits of this approach may include a decrease in the burden on healthcare systems, an enhancement in the patient's quality of life, and a reduction in the costs linked with long-term maintenance therapy. Furthermore, we anticipate that by stopping maintenance chemotherapy at 120 weeks for all males, we can significantly reduce the incidence of late CMV and EBV reactivation. This amended Total 15 protocol may serve as a model for use in other low to middle income countries in our region. Thank you.